Um, Hello, John.
Hello, is this Sudipka?
Yeah, I am in, but I did not get any video connection.
No, you have it now. You have a connection right now. You're in the webinar. You need to turn your camera on.
But my camera is on. Camera is working.
It doesn't look like it. It's not even connected. Okay, your volume's working, I mean, your audio, but your camera's not even on, not even connected to the internet. Not even connected to the conference.
Hello.
Yeah, okay, I'm trying to promote you, but you declined to come in, which I can't understand the reasoning. It should work now.
Yeah.
There you
It
go.
works now.
Oh, nice background.
Yeah.
We'll wait a few minutes.
Okay, we can wait few minutes for
Yeah,
participants.
there's no hurry, no hurry.
Okay.
Tell the speaker to come, of course. The other speaker.
Yeah, another speaker, I just talked with her just a couple of minutes back. She's okay now and she will join very soon.
Okay,
And if she make late, so I will give my speech first.
okay,
She will give the second speech.
okay.
Panelist is on the screen, I know. Panelist is active now. So everybody is okay now.
Okay. I'm hoping to get a few more.
So, Prashanto, you can open the camera of Professor Ekramullah, sir.
I'm sorry, I didn't understand you.
Not for you. I give some instruction to one of our boys.
Okay. I need a translator. Can you type what you said? I can't understand you. Just put it in the chat, put it in the chat.
Okay. Share.
Oh, there you go. Okay, we got someone televising something there. Well, looks like a camera, televising from a security camera. You see that? That's the kind of spot there can be a few physicians watching. Like where he's at now, or students, they could come in there if they wanted. Can you hear me, PNS? Can you hear me okay?
Yeah, I hear you very clearly.
How about, no, I'm talking about the other gentleman, the PNS, NINS.
So, Professor Ekramullah, sir, can you hear us clearly?
Yes, I can hear you clearly.
Okay, thank you, sir.
Good morning.
Can you hear me?
Yes.
He is one of our panelists. He is senior to me. He actually established our department. He is Professor Sheikh Mohammad Ekramullah, and he is working as a panelist today.
Okay. And Bajoy Kumar, is he?
Vijay Kumar, you know, he is a very enthusiastic man. He is a doctor. That means he performing PhD. His elder son, he has a history of hydrocephalus, who was treated by us in our National Institute of Neuroscience, and now doing very well. And this man, Dr. Bijoy, is dedicated for hydrocephalus patient. Now he is doing a good research for hydrocephalus to understanding its etiology and demographic character in our situation.
Okay,
So
he declines to come in. He doesn't want to come in. He doesn't have a camera.
Maybe
Bajoy, you have a camera? Yeah, he could
He
be in
is
a
mute.
hospital. Yeah, maybe
Bijoy
he's
is
in the
mute.
hospital. But Joey, do you have your camera on?
Yes,
Bijoy,
sir.
okay.
Yeah, you need to turn your camera on.
Bijoy, please open your camera.
Yeah, it's not on. Your camera's not even on. At the bottom of the Zoom screen, there's a picture of a camera. You need to click on it. That says start video. Do you see it at the bottom left? Bijoy, do you see it at the bottom left of your screen? Picture of a camera. Click on that.
Not now. TNS means লেখা আছে।
So
Okay,
So-
yeah, there you go. There you go.
Can you-
You're-
just I check that sharing is okay or not. Now
Yeah,
it
it's
is
good.
okay.
Okay,
it's
okay,
good.
okay. No, wait, listen. You have
Okay.
to, no, that's not good. Do it again. You need to put it in presentation mode. Let me show you right now. Okay, go on the share again, please.
Okay.
Okay, now that's not good. That only shows part of the screen. Okay, so you have to put it on presentation mode.
Now it's
Yeah.
okay.
But there's two screens there. The next slide is, yeah, I guess that's fine. That's fine. Yeah, that's fine. That's fine. That'll come. Well, no, it's not fine. It's not the whole screen. Let's get the whole screen. No, no. You see the right screen? That shouldn't even be up there. It should be just the left side that's on. So, that's it. There you go. There you go. See that? See it now? It's full screen. You see it?
So now it's okay.
Yeah, now it's good. Now it's good.
Okay. Thank you. So
That's
now I
good.
stop sharing for.
No, I haven't introduced, we haven't started yet. We're just practicing,
Okay.
okay? Okay. We'll start in a couple minutes. Okay. Okay, we start in a couple minutes, okay? Okay. You ready to start?
We can start at first. Professor Sheikh Muhammad Ikramullah, he can introduce us. And what happened, our first speaker, she lost his electricity connection, and possibly within 15 to 20 minutes, she will come in the Zoom.
Okay,
So by
you're gonna
this
be
time,
first. You're gonna be
can,
first. You're gonna
yeah,
be first,
yeah,
right?
I can present my one at first.
Okay, now is someone gonna introduce you? The panelists gonna introduce you? Or should I introduce you?
Professor Ikramullah sir, you can introduce us and give a brief note regarding the hydrocephalus and its
Okay,
basic.
who is going to introduce you, or should I introduce you?
You can, or Professor Ikramullah sir can.
Okay, I'll do it. I'll do it. Okay, you ready to start?
Sure.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning. This is Dr. John Bennett broadcasting from beautiful Miami Beach in Florida, the home of Neurosurgical TV. We have our first Bangladesh Pediatric Neurosurgery Grand Rounds, more or less. It's our first meeting with a group of Bangladesh neurosurgeons. I ran into Sudipka on the internet, and he asked me if he wanted to do a conference in pediatric neurosurgery, and that's something we really need on the internet. At any rate, let me introduce Sudipka Kumar Mukherjee from Bangalore. He is going to give the first webcast, and he'll describe it. Welcome, Sudipka. Could you please introduce yourself and your topic?
And at first, Professor Sheikh Muhammad Ikramullah sir, please say something on hydrocephalus and its basic. Then I will start.
Okay.
Good evening, everyone. Thank you all for joining the Zoom session today as we delve into an essential topic, the basic concept of hydrocephalus. I am Professor Ikramullah, and I am thrilled to be your host for this educational discussion. Hydrocephalus is a neurological condition that may not be widely known, but it affects the lives of thousands of individuals worldwide. Through this session, we aim to raise awareness, deepen our understanding, and foster compassion for those living with this condition and their families. Over the next 5 sessions, we will explore the fundamental aspects of hydrocephalus from its definition and cause to its diagnosis and treatment options. We will learn about the different types of hydrocephalus, how it presents in various age groups, and the impact it can have on individual lives. As we embark on this learning journey together, I encourage all participants to actively engage, ask questions, and share your thoughts and experiences. Our collective knowledge and insights will enrich the discussion and contribute to a comprehensive understanding of hydrocephalus. Please feel free to use the chat function to type your question, and we will address them as we progress. Our aim is to create an inclusive and interactive environment where everyone feels comfortable participating. By the end of this session, I hope we will all have a clearer understanding of hydrocephalus, its challenges, and the importance of early detection and intervention. Together, we can empower ourselves to be more supportive and informed advocates for those impacted by this neurological condition. Once again, thank you for being here today, and let's make the most of this time as we explore basics and understanding of this vital medical topic. Now, without further ado, let's begin our journey into the worldwide of hydrocephalus. The first, Dr. Sudipta Kumar Mukherjee, the Associate Professor and Head, Pediatric Neurosurgery Department, National Institute of Neuroscience, will present his topic. Please Dr. Sudipta Kumar Mukherjee, please start your lecture.
Thanks, Professor Ekramullah sir, for introducing me and to give me a opportunity to say something regarding hydrocephalus.
Right.
Hydrocephalus is not a single disease entity. It has a diverse etiology. Its treatment methodology is different type and outcome is also diverse. And though it is a single disease, but its etiology and outcome is different in different socioeconomic condition and different part of the world. So we need to understand the basics of hydrocephalus in each part of the world to tackle the disease condition wisely. So my topics, actually, this is the second part of the today's speech. I want to talk about two types of hydrocephalus that was complicated. The first part of the speech should be delivered in second due to technical error by Dr. Tasfiya M. Chaudhary. I want to present my part now. I want to share my screen.
Over.
Just do the same thing you did before. There, perfect, perfect.
Okay, so as it is perfect, so I can start. So I want to, there is a lot of complicated hydrocephalus. Complication due to disease process itself, complication due to treatment failure. So complicated hydrocephalus, that not means that all disease process is complicated. Today I want to present two hydrocephalus that in that place the disease process is complicated. The first one is multiloculated or multiseptate hydrocephalus. So what does it mean? See, there are three CT scan images. The left side, there is a normal brain. In the center of the brain, there is a black or hypodense area, that is the water or CSF. And in the peripheral part, that is a hyperdense or white area, that is the bones or skull. And in between skull and CSF, that means ventricle, that is the brain parenchyma. But in the second image, you saw the water part, that is the black part is widening, the brain or parenchyma is reducing, the bones is as before. But in third part, what you see? There is a multiple septation or trabeculae within the water part. And brain is very thin. In some place, brain is merely present. And as because this is the MRI, there is no specific hyperdensity in the periphery. Rather, there is a hyperdense rim due to fat. Now, what are the ideal treatment of multiloculated hydrocephalus? The ideal treatment of multiloculated hydrocephalus is the direct visualization of the septum, make fenestration or hole within the septum, that is called septostomy, and do it preferably by flexible endoscope. And when all cavity is converted to a single cavity, so after then we can do CSF diversion either by VP shunt or by endoscopic third ventriculostomy. Intraoperative irrigation is very much mandatory in some cases where we get preoperative hyperdensity in CT scan. That means there may be high protein content or infective. Preoperative lumbar puncture show turbid or blood mixed sample. Intraoperative exudate or turbid sample. So these three are the indication of intraoperative irrigation for septated hydrocephalus. See, in the lowest part, there is a graph. It shows that intraoperative irrigation show good Glasgow outcome score rather than non-irrigated patient. That is the result of a randomized control study. That is a short study in our center, which was published already. So this is a flow chart that was developed by us, and it was published also, that what is the decision of septated hydrocephalus management during endoscopic third ventriculostomy. What we can do? We can do three things. We can do VP shunt, or we can do endoscopic third ventriculostomy, adjunct CPC maybe, and we can do external ventricular drainage. When we can do which one? We at first check the CSF color. After getting the endoscope inside, we check the CSF color. If CSF is clear, the first thing, observe the third ventricular floor. If third ventricular floor is accessible, we can do endoscopic third ventriculostomy. And adjunct CPC may do in indicative cases. Later, we can check for scarring in prepontine cistern. If there is scarring, additional VP shunt may needed. If there is no scarring, so ETB CPC is enough. But when in third ventricular floor is not accessible, so ventriculoperitoneal shunt is only one way. But what we can do in turbid CSF? In turbid CSF, we can do only irrigation, aspiration, then temporary CSF diversion. It may be external ventricular drainage, it may be ventriculosubgaleal shunt, it may be Umaya reservoir. So three things we should check: observe CSF color, observe third ventricular floor accessibility, observe prepontine cistern. These three things give you three decisions. We can do VP shunt, we can do external ventricular drainage or VHG, or we can do ETB. So this flow chart you can follow in your routine practice in case of septated hydrocephalus. So what is the importance of prepontine scarring or scarring in prepontine cistern? How do you find out it? You can check a very deductive and elaborative lecture by Professor Kulkarni from the Hospital for Sick Children in Canada. In his lecture, he mentioned that CIS protocol MRI is very important to detect the scarring in prepontine cistern preoperatively. You see in the left-hand MRI, in front of pons, in front of basilar artery, there is a scar. And almost all prepontine cistern scar is there. But in right-hand side, in front of pons, in around the basilar artery, the prepontine cistern is very much clear. So a good CIS protocol MRI can dictate you preoperatively that prepontine cisternal scarring present or not. If there is ETB failure and if there is prepontine cisternal scarring, there is no role of redo ETB, because scarring in cistern may causes failure of ETB in next session also. So in case of scarred prepontine cistern, the only one way in case of ETB failure is doing VP shunt. If there is iatrogenic bleeding in prepontine cistern, this may happen in inflamed cases. So we give irrigation and maintain positive pressure in prepontine cistern, then confirm the endoscopic third ventriculostomy and CPC. But antibiotic and fibrinolytic intraoperatively not used in our center. So my second topic, that is another complicated and most that means hopeless situation in pediatric neurosurgery, that is called tuberculous meningitis hydrocephalus. Tuberculosis may not highly present in some part of the world, but this part of the world is still now tuberculosis prevalence is not very high, but it's still now tuberculosis is present. Hydrocephalus in these topics, actually I based on a very famous article which was published from CMC Vellore Hospital by Professor Vedantam Rajashekar, and Professor Rajashekar et al. Published this article of tuberculosis, meningitis, and hydrocephalus. Hydrocephalus is one of the most complicated complication. Most of the common complication in tuberculosis meningitis. The incidence of tuberculosis meningitis hydrocephalus is 62 to 95%. It is almost always present in patients who have had this disease 4 to 6 weeks back, and it is more frequent and severe in children. So there are two pathogenesis in case of TBM hydrocephalus. It may be communicating one, it may be non-communicating one. If you check the right side, there is a graph that how CSF is formed, how CSF is circulated through foramen of Monro, cerebral aqueduct, then foramen of Luska and Medendi, then subarachnoid space go to the arachnoid granulation. In case of tuberculosis, arachnoid granulation due to inflammation, it may losses or reduces its absorptive capacity. So there is communicating hydrocephalus developed due to less absorption, and inflammation of choroid plexus and ependyma also causes overproduction of CSF in acute phase of illness. So two things is important: overproduction from choroid plexus. On the other hand, there is a less absorption in the arachnoid granulation. So there is a chance of communicating hydrocephalus. And there are 80% communicating hydrocephalus occur in TBM hydrocephalus. The second one is obstructive hydrocephalus. In earlier stage, due to thick gelatinous exudate in the basal system, causes occlusion of foramina mezendi, Luska, and subarachnoid spaces, and thus stop circulation of CSF. Even ependymitis in foramen of Monro and aqueduct also blocks the circulation. In the later stage, what happened? Scarring in the subarachnoid space causes occlusion of foramen of Mezendi or Luska, and scarring also causes occlusion in subarachnoid space, that leads to later stage obstructive hydrocephalus. Though obstructive hydrocephalus in TBM meningitis only 20%, but in earlier stage the cause is exudate, the later stage cause is scarring. And it is evident that hydrocephalus is common and severe in children in TBM. So in 70% occurs in children. So in children, be cautious. Hydrocephalus are more common in later stage of the disease due to scarring. Clinical picture. The most important clinical picture of TBM hydrocephalus is altered sensorium. You have a known case of TBM, that patient losses or changes its sensorium, that means level of consciousness, is the most important indicator of developing hydrocephalus. The second thing, you must check fundus. Fundus, this swelling, is the most important parameter of needing surgery. And second thing, increasing headache with or without vomiting and blurring vision is the important parameter, important clinical parameter of TBM hydrocephalus. This is the most important slide of my presentation. This is the CMC Vellore grading. CMC Vellore, you know, this is the, so far I know, this is the first hospital in the medical hospital in subcontinent. And their service is undoubtedly very good. Professor Rajashekar and his groups did a lot of study on TBM hydrocephalus, and I collect this grading system from him personally. This is the modified one. Initially, he did not include GCS within the grading. He only say about the sensorium. But later he added GCS and give the name modified Velour scale for TBM hydrocephalus. The grade 1, the patient have GCS 15, that is fully conscious oriented. Patient have headache, vomiting, neck stiffness, but no neurological deficit. The second grade, same GCS, that means patient conscious oriented, but there are few neurological deficits. Third grade, GCS is low, that is very important. Neurological deficit may or may not present. In previous slide, I tell that sensorium is the most important parameter in TBM hydrocephalus, that is GCS. In the fourth grade, you see the very poor GCS, only 3 to 8. Neurological deficit may or may not present. So neurological deficit is not the important parameter. Important parameter is GCS. That means sensorium. Imaging, CT scan is the preferred imaging, and from CT scan we may know the ventricular size, subependymal seepage, presence of any infarct and tuberculoma, presence of basal exudate. Contrast may necessary, not always. And CT scan is good for pediatric because it may not, no need of any sedation and very short time investigation, but CT scan definitely has some limitation. For that reason, sometime we need MRI. From imaging, we may know that if there is a lateral ventricular enlargement, all other ventricle is normal, so there may be foramen of Monro blockage. If triventriculomegaly, aqueductal blockage may be. If all ventricle is enlarged, foramen of Lusca and Mezendi may be blocked. If subarachnoid space is blocked, all ventricle plus subarachnoid space widening may found. If there is blockage in the arachnoid granulation, that means arachnoid granulation absorptive capacity is poor. So there is a widening in subarachnoid space as well as all ventricle is wide. What is the medical treatment? Medical treatment should be steroid, that is dexamethasone. Second one, antitubercular drug. Dehydrating agent, that means mannitol may be necessary, but it works for short time. Diuretics like furosemide or acetazolamide may be helpful, but not for a longer period. And this fourth thing is important for in the side of medication. What about the duration of NTTB? NTTB duration, there is a lot of controversy. We neurologists and neurosurgeons believe minimum 18 months NTTB is mandatory, sometime more. Till the other feature of tuberculoma and the other features subsided, NTTB should continue. There are some other grading of TBM hydrocephalus, like MRC grading developed by British Medical Council. They actually does not direct include the Glasgow Coma scale directly, but they say fully conscious, no paresis, decreased level of consciousness, localizing pain, and deeply comatose patient with gross paresis. Now we are the phase of treatment. Medical management, especially patient with beta sensorium, give medical management. If they definitely have communicating hydrocephalus, medical management may helpful. But However, if the patient monitored should carefully during medical management, what are the point we monitor? We monitor for any worsening of sensorium. Next, lack of improvement after medical management. So we should continue medical management by proper monitoring. We should monitor sensorium. We should monitor for improvement. But indication of surgery. Patient with grade 1 and 2 are doing very better with surgery. Earliest surgery doing better. In South African group, they have some analysis. They get surgery may do early, but delayed surgery may do also some cases. Why some patient is sensorium is not improving even after CSF diversion? The main reason is encephalitis and ischemia caused by arteritis. The two reasons is not related with ventriculomegaly. By CSF diversion, we only reduce ventriculomegaly, reduce ICP. But encephalitis and ischemia caused by arteritis, that is another part of disease process. So after doing CSF diversion, it is not guaranteed or mandatory that all patients' sensorium will improve. Because this disease has many ways to damage the brain. CSF ventriculomegaly is one way, but other way to damage brain, that is encephalitis and arteritis. So these two procedures may continue to damage brain for a certain period. So some patient who already develop infarction in basal ganglia, thalamus or brainstem, they are worsening gradually. Especially in grade 3 and grade 4 patient, it becomes difficult to determine the cause of alteration of sensorium. Now, ETB. Truly, ETB may not successful in TBM hydrocephalus because there is exudate in basal cistern. But in some group, they did ETB and got good result. Maybe there is some absorptive capacity in Virchow-Robin space that causes good result of ETB in communicating hydrocephalus. That's why in some groups, they get good result of ETB in TBM hydrocephalus patient. Singh et al., they get success rate 77%. And they have early recovery 60% in ETB in case of TBM hydrocephalus. They did this study in GB Pant Hospital in India. There are two studies by Hussein et al. They get good result, success rate in ETB is 68% and 73%. From South Africa, Cape Town Red Cross Hospital, Higazi et al., they get 41% success rate. See, a good number of patients doing better after ETB in case of TBM hydrocephalus. The selection of patient is important. Not all the patient. Selected patient may be benefited very nicely. Why ETB is difficult? That means one ETB will abandon in case of TBM hydrocephalus. If we see there is a lot of exudate, third ventricular floor is deformed and it is not accessible. The next thing, there is a subarachnoid space, prepontine cistern, everything is obliterated by exudate. So in this two type of case, where the third ventricular anatomy is lost, floor is not accessible, and subarachnoid space is completely occluded by exudate. In this type of case, ETB should abandon in case of TBM hydrocephalus. Why ETB is not doing good in early stage? ETB is difficult in early stage. This is very important. In early stage of inflammation, there is a more chance of bleeding. There is a inflammation is continued. So ETB is may not possible in very early stage, or ETB failure rate is very early stage of any inflammation. Complication of surgery. TBM hydrocephalus shunt surgery complication rate is very high, and in poor general condition, in bad GCS, high protein, high cellular content, active bleeding, so more complication. We get 3 results. One from Agarwal et al. They get 37 cases. They have 30% complication. Polar et al. They have 114 patient. They have 22% complication. This is a very famous paper from Professor Sandeep Chatterjee, Kolkata, and Dr. Sheel. They have 37 patients. Their infection rate is 15.6%, and they have shunt revision rate is 43.8%. So very high. So mortality rate is also very high in TBM hydrocephalus. If you check that Professor Bhagavati et al. Published a paper in 1971, only 7 cases, they have mortality 3. Upadhyay, they did 9 cases, mortality 4. And Palur et al., they have 14 patients, mortality 42%. So high mortality in almost all series. So see, there is a balance. If there is a good sensorium, good outcome, poor sensorium, very bad outcome. So we should approach to patient during the good sensorium. If sensorium already bad, so outcome is not good. So those doctor who take care, this is the important message from this speech. Those doctor who take care the TBM hydrocephalus from very early period, please check sensorium every day, every time. If you feel sensorium is decreasing, please consult with surgeon as early as possible. If your patient say headache, blurring vision, please contact with surgeon as early as possible. Otherwise, when patient develop poor sensorium, you will not get a very good result. Prognostic factor. There are several prognostic factors, that is age, duration of altered sensorium, cell count, cell protein level, shunt revision, bilateral shunt. This is developed by Vellore group. So this is a flow chart developed by Vellore group. So when they get any patient with TBM hydrocephalus, they divide the patient into grading 1 to 4 by clinical and radiological parameter. Grade 1 to 3, if the duration is less than 4 weeks, deficient more than 4 weeks, ETB may do. If patient is improving by the time or improved, so you can wait or do a EVD for 48 hours. If after doing EVD, patient improving, do conservative management, and you may not need any CSF, permanent CSF diversion, but this type of practice may produce further complication of EVD, because you know long-term EVD causes EVD-induced infection also. So when I communicate with Professor Rajashekar in 2019, he told me at that time that he still, at that time, he also practiced the previous valor grading as well as valor grade 1 to 3. He did shunt, valor grade 4, he gave a trial for EVD 5 days maximum. If there is basal ganglia infarction, then no shunt. So this was a letter from Professor Rajashekar for he wished us for doing much more surgery, and we can work in this field. And thank you everybody for hearing my lecture, though it is clumsy and it was the complicated part of hydrocephalus. Now I hand over my mic to Professor Sheikh Mohammad Ikramullah sir to say something and give some comments. And if there is any question from audience, please ask. Thank you very much.
Okay, thank you very much. I believe the moderator is going to take over. Okay, the moderator's there. Could you please take over?
Thank you. Thank you, Dr. Sudipto Kumar Mukherjee, for your nice presentation on multiloculated hydrocephalus and tuberculous meningitis hydrocephalus. So we understand that multiloculated hydrocephalus, we can do the VP shunt surgery, ETV, and ventriculo-subgaleal shunt. And in tuberculous meningitis hydrocephalus, the good sensorium is a good indicator for surgery, and the poor sensorium is a good indicator for surgery. Bad, it's a poor indicator. Poor sensorium is a bad indicator for surgery. So I think, how about the second speaker, Dr. Tasfia M. Choudhury? Is she ready for presentation?
Yes, sir, I'm ready for presentation.
So I think Dr. Tasfia M. Choudhury, she will present his lecture on basic concept of hydrocephalus. Please start, Dr. Tasfia M. Choudhury. Please.
Yeah, sir, can you see my screen?
Yes.
Yes,
can
it
see
needs to.
clearly.
Yeah, there you go. Perfect. Perfect.
Yes, perfect.
Okay.
Start.
Good evening, everyone. My name is Dr. Tasfia Mumtaz Choudhury. I'm a resident Phase B of Neurosurgery at the National Institute of Neurosciences, Zahn Hospital. I will provide a brief overview and some basic concepts over the topic hydrocephalus. So hydrocephalus is the word is derived. It's a Greek word that is derived from the words hydro, which means water, and kephali, which means head. And it is one of the most commonly encountered conditions in neurosurgery. And it was described as earliest as the 5th century BC by Hippocrates, who described the clinical presentation of hydrocephalus secondary to water accumulation within the head. And it was not until the late 19th century that the current accepted physiology of the CSF production and absorption was clarified. So what is the cerebrospinal fluid? As you all know, that it is a clear colorless fluid that surrounds the brain and the spinal cord. And it mainly functions as a shock absorber for the central nervous system and also has some immunological functions. So it will circulate within the subarachnoid space and between the arachnoid spaces. Now, the production of cerebrospinal fluid, the cerebrospinal fluid is produced from two compartments, namely the intracranial and the spinal compartment. About 80% of it is produced by the choroid plexus of the lateral ventricle and rest from third and fourth ventricle, 20% from the interstitial space and ependymal lining, and the dura of the nerve root sleeves also produce CSF. The CSF is absorbed at the level of arachnoid villi that are found in proximity to the dural venous sinuses. The CSF formation rate is not dependent on pressure, but the absorption is pressure dependent. So now the production rate and volume. In newborn, the total volume is about 5 ml. In adult, it is about 150 ml. And the rate of production is about 25 milliliter per day in newborns. And in adult, it is about 450 to 750 and on average of 500 milliliter per day. And the pressure in newborn is 9 to 12 centimeter of water. And the pressure in infants, normal is less than 15 centimeter of water. And in case of adult, normal is less than 18 to 20 centimeter of water. This is a diagram that shows the fluid, the flow of the cerebrospinal fluid through the ventricular system. After being produced by the choroid plexus in the ventricles, from the lateral ventricles, the CSF will flow through the foramen of Monro into the third ventricle. And from the third ventricle, it will flow into the fourth ventricle through the aqueduct of Sylvius. And from the fourth ventricle through the basal foramina to lateral foramina of Luschka and foramen of Magenti into the central canal. And eventually it is absorbed into the arachnoid granulations. Now, one factor is to be noted is the Monro-Kelly doctrine. We all know that it states that the sum of the intracranial contents, that is the blood, CSF, and the brain parenchyma, should remain constant in the fixed rigid container that is the skull. So if there is an increase in any one of the components, it is compensated by a decrease in one or two of the other components. Now, what is hydrocephalus? Hydrocephalus, by definition, is an abnormal accumulation of cerebrospinal fluid within the ventricles of the brain. The epidemiology estimated prevalence is about 1 to 1.5%, and the incidence of congenital hydrocephalus is 0.9 to 1.8 per 1,000 births. The classification, there are different classification systems for hydrocephalus. One classification is that hydrocephalus can be classified into non-obstructive and obstructive variety. Non-obstructive, that is ventricular enlargement without any obstruction to the flow of the CSF within the ventricles. And it is usually occurs due to overproduction of the CSF by the choroid plexus, and it is a very rare condition. The other is obstructive variety, that is, there is some kind of obstruction to the CSF flow. Now, it can be divided into communicating and non-communicating type, depending on the fact that if the obstruction is outside the ventricular system, and that is in the subarachnoid space or arachnoid villi, then it will be communicating. And this is seen in post-hemorrhagic or post-traumatic conditions where there is inflammation of the arachnoid villi and fibrosis, and hence resulting in a communicating hydrocephalus. Non-communicating hydrocephalus is due to obstruction within the ventricular system, could be in the aqueduct, in the basal foramina or foramen of Monro level, etc. Another classification that Gower used in 1888, and it is still useful, is acute or chronic or primary or secondary hydrocephalus. Acute hydrocephalus implies that there is rapid decompensation, and this is usually associated with an underlying pathology, and it presents as an elevated intracranial pressure. And chronic hydrocephalus could either be idiopathic or secondary to a known pathological condition, and it is associated with lower pressure or normal intracranial pressure. And primary or secondary hydrocephalus, in secondary hydrocephalus, it could be secondary to tumor or hemorrhage or trauma, infection, etc. Now, what are the etiology of hydrocephalus? Hydrocephalus could be due to congenital conditions, it could be due to acquired conditions. Congenital conditions include Chiari-1 malformation or Chiari-2 malformation, could be due to aqueductal stenosis, which could be primary, or it could be secondary to intrauterine infection or germinal matrix hemorrhage, as seen in premature infants. Could be due to Dandy-Walker malformation, where we know that there is cerebellar Vermean hypoplasia with cerebellar atrophy, and there is enlargement of the fourth ventricular cyst. And then there is another cause, that is hydranencephaly, which will be discussed later. Acquired causes include post-infectious, mostly meningitis, could be tubercular meningitis. It could be due to fungal infections such as neurocysticercosis. There could be another cause, that is post-hemorrhagic subarachnoid or intraventricular hemorrhage, post-traumatic, or secondary to mass lesions such as tumors, especially tumors in the posterior cranial fossa, vascular malformations, cysts, and post-operative, that is after tumor resection, including posterior fossa tumors. There could be hydrocephalus as a result of obstruction that might be present distal to the site of operation. This is a picture showing a CT scan of a baby showing enlarged ventricles. And this is another CT scan that shows multiloculated hydrocephalus. Now, what are the clinical features of patients with hydrocephalus? So young children will present with symptoms of irritability with poor head control, nausea, vomiting. The parents will complain of failure to thrive or developmental delay, abnormalities in the occipitofrontal circumference. We will see that the patient has craniofacial asymmetry, full bulging anterior fontanelle, frontal bossing. There can be enlargement and engorgement of the scalp veins, and this is due to reversal of the flow from the intracerebral sinuses due to increased intracranial pressure. There could be abducens palsy due to the long intracranial course of the nerve that renders it sensitive to pressure. Setting sun sign, that is up-gaze palsy due to pressure on the region of the suprapineal recess. Reflexes could be hyperactive and irregular respirations with apneic spells. Older children may present with headaches, that is dull headache, typically upon awakening, blurring of vision, lethargy, decreased food intake, vomiting, poor performances in school, endocrinopathies, and they too can have lateral rectus palsies, clonus, hyperreflexia, and papilledema. This is a picture that shows craniofacial asymmetry in the baby. And as you can see, there is a venous engorgement. And this is a picture showing setting sun appearance in the child. Now, what is this occipital frontal circumference? Now, we can measure the occipital frontal circumference using a non-stretchable tape. The circumference of the head is measured by placing it just above the supraorbital ridge anteriorly and around the most prominent part of the occiput posteriorly and staying above the ears. And that tape should be pulled in order to compress the hair. We will take two separate measurements by repositioning the tape each time. And if the measurement is less than 2 millimeter difference, we can take an average. But if the difference is more than 2 millimeter, then we have to take another measurement, and then we will average between the two closest measurements. This is a picture as showing how to measure the occipitofrontal circumference. Now, the normal occipitofrontal circumference of a full-term infant ranges from 33 to 36 centimeter. On an average, it is said that it increases for 2 centimeter per month up to 3 months, then 1 centimeter per month from 3 to 6 months of age, and then 0.5 centimeter per month from 7 to 12 months of age. Now, abnormal occipitofrontal circumference is considered when we will see that there is a progressive upward deviation from the normal curve that is plotted for normal occipitofrontal circumference for each specific age group in case of male and in case of female. If there is a continued head growth for more than 1.25 centimeter per week, or if we see that the occipitofrontal circumference is approaching above 2 standard deviations above the normal, or the head circumference is out of proportion to the body length or weight, even if it's within the normal limits for that particular age, it is considered to be abnormal. Now, what are the investigations done for diagnosing hydrocephalus? In utero, ultrasound studies and fetal MRIs can be done to diagnose hydrocephalus. In infants with intraventricular hemorrhages, if hydrocephalus is suspected, then ultrasonography can be used to evaluate the ventricles because the anterior fontanelle, which is open, provides a good window for ventricular visualization. But the standard imaging for the diagnosis of hydrocephalus is CT scan. And CT scan provides an effective way for visualizing the ventricular morphology, for seeing the blood products that is complicating the picture of hydrocephalus, for seeing the signs of raised intracranial pressure, such as sulcal or gyral effacement or obliteration of the subarachnoid spaces. MRI studies are also particularly useful because it helps to delineate the disease that is responsible for CSF pathway obstruction, for example, a tumor. And it also provides better evaluation of the posterior fossa and foramen magnum. And evaluation of the ventricular anatomy can be done in the coronal, sagittal, and axial planes. Now, what is the CT scan criteria? In CT scan, there are different types of criteria. So one is known as the Evans ratio. In order to calculate the Evans ratio, we need to find the slice of the CT scan which has the largest internal bipyramidal diameter of the skull. And then the frontal horns are also measured in the same slice. So Evans ratio is the ratio between the diameter of the frontal horn and the maximum biparietal diameter. And if the ratio is more than 0.5, then it is considered to be hydrocephalus. The problem with Evans ratio is that it varies with the angle of the slice. The maximal biparietal diameter may not be on the same slice as the maximal frontal horn diameter. And the measures that rely on frontal horn diameter tend to underestimate the hydrocephalus in pediatrics due to disproportionate dilatation of the occipital horns. This is a slice showing this is the maximum biparietal diameter, and this is the diameter of the frontal horn. And this ratio of frontal horn diameter to the maximum biparietal diameter is known as the Evans ratio. There is another criteria, that is, if the size of both the temporal horn of the lateral ventricle is 2 millimeter in width, and the sylvian interhemispheric fissure and the cerebral sulci are not visible, or both the temporal horns are 2 millimeter and the ratio of the frontal horn is more than 0.5, then it is considered to be hydrocephalus. Other features include ballooning of the frontal horns of the lateral ventricles, known as the Mickey Mouse ventricle, widening of the third ventricle, periventricular low density on the CT scan. And now we will discuss the features that are indicative of chronic hydrocephalus. The features are copper-bitten appearance seen on plain skull X-ray, but for this to correlate with increased ICP, it should be associated with the following. There is erosion of sella turcica, erosion of the dorsum sella. Then the temporal horns may be less prominent on imaging than in acute hydrocephalus. Then there are also changes of the corpus callosum that is to be appreciated. That is thinning of the corpus callosum or upward bowing. And in case of infants, we can see that there is splaying of the cranial sutures. There are certain conditions that may mimic hydrocephalus, developmental anomalies, where ventricles or portion of ventricles appear to be enlarged. For example, agenesis of the corpus callosum, then hydranencephaly, as mentioned earlier. It's a post-neurulation defect where there is either total or near total absence of the cerebrum, most commonly due to bilateral IC infarct. And it is very important to differentiate hydranencephaly from severe hydrocephalus, because if a shunt procedure is done for maximal hydrocephalus, that is true hydrocephalus, then there may be some re-expansion of the cortical mantle. But in case of hydranencephaly, this re-expansion will not be seen. And one of the investigations that is commonly used to differentiate is EEG. If there is abnormal spike in the EEG in a normal background, then it indicates maximal hydrocephalus. But if there is no spike, then it indicates hydranencephaly. Other conditions include triventricular hydrocephalus, which occurs due to aqueductal stenosis, either narrowing or complete blockage of the sylvian aqueduct, produces an enlarged third and lateral ventricle, but normal size fourth ventricle. Another condition is known as the entrapped fourth ventricle or the isolated fourth ventricle. There is a fourth ventricle that will not communicate with the third ventricle through sylvian aqueduct, nor with the basal cisterns through the basal foramina. And this is usually seen with chronic shunting of the lateral ventricle, especially in post-infectious hydrocephalus or those with repeated shunt, because there is adhesion from prolonged apposition of the ependymal lining of the aqueduct due to diversion of the CSF through the shunt. And it can also occur in Dandy-Walker malformation if the aqueduct is also obstructed. This is a CT scan showing the entrapped fourth ventricle. You can see that the fourth ventricle is enlarged, but the third ventricle and the lateral ventricles are not. Now, what is arrested hydrocephalus? It refers to a situation where there is no progression or deleterious sequelae due to hydrocephalus that would require the presence of a CSF shunt. And arrested hydrocephalus satisfies the following criteria in the absence of a CSF shunt. That is a near normal ventricular size, normal head growth curve, and continued psychomotor development. Now, what is the treatment of hydrocephalus? There are two types of treatment. One is the non-surgical treatment, the other is the surgical treatment. The non-surgical treatment mainly serves only to temporize hydrocephalus until a shunt is placed. And here, pharmacological treatment is also used and some other kinds of treatment used. Pharmacological treatment is mainly aimed for decreasing the CSF production or increasing the absorption. The medications commonly used are acetazolamide, which is a carbonic anhydrase inhibitor, or furosemide, which is a loop diuretic. However, studies have shown that using these result in increased neurological sequelae and increased shunt placement rate, as a result of which these drugs are not commonly used. And also the use of hyaluronidase to promote increased CSF absorption has been used, but with mixed success. Its efficacy as a means to obviate shunting has not yet been shown. Another procedure, which is non-surgical, is intermittent CSF removal through ventricular puncture or lumbar puncture. And it is also used as a means for temporizing hydrocephalus until a more definitive treatment can be undertaken. Now, the surgical treatment. Surgical treatment includes third ventriculostomy. It includes CSF diversion procedures such as shunting, eliminating the obstruction, for example, opening a stenosylvian aqueduct, choroid plexectomy. Although it may reduce the rate of CSF production, but it does not completely halt the CSF production because, as mentioned earlier, CSF is produced from ependymal lining of the ventricles and also from the dural sleeves of the spinal nerve roots. There are various types of shunt: ventriculoperitoneal shunt, ventriculoatrial shunt. If there are problems in the peritoneal cavity, suppose the child has peritonitis or any other conditions that create a problem for ventriculoperitoneal shunting, then the shunt can be placed in spaces such as pleural space, but this is recommended only for patients more than 7 years of age. Or the distal catheter can be placed in gallbladder or even in the ureter or bladder. Then there is another called the lumboperitoneal shunt or the cyst or subdural shunt. Here we will be discussing the common ventriculoperitoneal shunt and the endoscopic third ventriculostomy. Now, ventriculoperitoneal shunt are of various types. There are pressure-dependent shunt, which will allow the CSF to flow across the valve when the pressure differentials will exceed its preset opening pressure. There is flow-dependent shunt, which will allow a constant flow of CSF across different pressure gradients with different patient position. And there is valve, another shunt, which has a pressure-dependent valve with anti-siphon component. There are also shunt which has programmable valve or non-programmable valve. In programmable valve, they can have their preset pressure changed by extrinsic devices without requiring surgery to change the valve itself. But it is to be noted that these programming devices work through a magnetic field interaction. So exposing these patients to MRIs inadvertently can change the valve setting. So patients with programmable valves should have their valve settings evaluated and reprogrammed appropriately after routine MRIs. Now, what are the sites for introduction of ventricular cannulation? There are 3 sites. One is the Cocker's point that gives access to the frontal horn of the lateral ventricle. There is the Keen's point, and there is the Frazier's point that gives access to the occipital horn of the lateral ventricle. Now, the Cocker's point is present in the 2 to 3 centimeter from the midline, 11 centimeter behind the mid-pupillary line, and 1 centimeter anterior to the coronal suture. The Keen's point is present at a point which is about 3 centimeter superior to and posterior to the ear pinna. And Frazier's point, about 6 to 7 centimeter above the inion and 3 to 4 centimeter from the midline. Now, how much of the proximal catheter is to be inserted into the ventricle? This can be measured preoperatively by seeing the CT scan. This is R and this is P. So we will measure the direction, we will measure the length from the outer table between the length between the bony outer tibia and the foramen of Monro. The shortest distance will be used as a measure for the insertion of the proximal tip of the catheter. Now, procedure. The proximal catheter is connected to a one-way valve, and that one-way valve is connected to another distal catheter, and which is passed subcutaneously through a tunneling device to the final destination. Patient will be placed supine with head turned sharply to the opposite side, as you can see in this picture. A shoulder roll is placed to facilitate the passing of the distal catheter from the head across the neck and clavicle to the abdomen. The abdomen is opened through a small ipsilateral parabolical incision that incises the anterior rectus sheath, blunt dissection of the rectus muscle, and then incises the posterior rectus sheath and the peritoneum. And a small dissector is used to verify the peritoneal location. The catheter is then passed into the peritoneal cavity, and care must be taken to place sufficient amount of distal catheter into the abdomen, about more than 30 to 40 centimeter, to avoid catheters pulling out of abdomen as the patient grows. This is the picture showing the procedure. And this is the proximal end is the entry point is selected, the Keynes point is selected as the entry point. And this is the abdomen. This is another picture showing the VP shunt procedure. This is a post-operative X-ray that is done in a child after insertion of the ventriculoperitoneal shunt. Now, follow-up. It is very important to follow up patient after ventriculoperitoneal shunt. And in follow-up, we will take history of the patient regarding the general condition of the patient. If there is any sign symptoms of complication, such as fever, or again, occurrence of vomiting, or if there is any redness or erythema at the site of insertion of the proximal catheter, then we will also physically examine the patient to see the occipito, measure the occipitofrontal circumference. We will check the valve of the ventriculoperitoneal shunt to see if it's working or not, and we will provide some, if we are in doubt as to some complications may arise, then we can go for X-ray or CT scan of X-ray of the abdomen or CT scan of the brain for further evaluation. Complications of ventriculoperitoneal shunt will be discussed in detail in further sessions. Moving on to another procedure, the endoscopic third ventriculostomy. This is a procedure, a means of bypassing a downstream obstruction, and when successful, it will eliminate the need for extracranial CSF shunting and the long-term complications that are associated with this procedure. Now, we need to determine which patients with obstructive hydrocephalus are good candidates for ETV, and for that, MRI will help us. It is important to see the anatomy of the floor of the third ventricle and the relationship of the basilar artery to the floor. If the floor of the third ventricle is very thick, then it will possess difficulty during procedure. This is the MRI showing the trajectory for endoscopic third ventriculostomy. The fenestration is done in the floor of the third ventricle, anterior to the mammillary body. I would like to show a video of endoscopic third ventriculostomy. Can you see the video?
Yeah, it's trying to load, but apparently,
No,
yeah, reload it. Okay. Okay.
we cannot see the video.
Video is not running, Pastia.
Okay.
Yeah, you have a poor connection. You cannot run video.
Oh, okay. Then I think I should move forward.
Yeah, move forward. Forget the video.
Okay. 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 So what are the contraindications to communicate to endoscopic third ventriculostomy. One is communicating hydrocephalus, and there are also low success rate if the patient has a pre-existing pathology, which includes history of previous shunt or previous subarachnoid hemorrhage, tumor, or significant adhesions are visible when perforating through the floor of the third ventricle, or previous whole brain radiation. This is a chart showing the ETV success score, and it is dependent upon three factors. One is the age, etiology, and previous shunt. So the total score is zero. The score ranges from 0 to 90%, and we can see that the ETV is usually less successful in children aged less than 6 months of age. Usually less than 40% is the total score, and if the score is if it's more than 70 to 80%, then it has a good success score. Now, what are the complications of ETV? It could be hypothalamic injury, injury to pituitary stalk resulting in complications such as diabetes insipidus, injury to the basilar artery, transient third or sixth nerve palsies, and uncontrollable bleeding. So as I have mentioned earlier, a total of 3 scores are used. And if the score is less than 40%, it will correlate with very low chance of success. If it is more than 80%, then better chance of success compared to shunting. And intermediate scores of 50 to 70%. In these cases, ETV had a high initial failure rate compared to shunt. But after 3 to 6 months, the balance shifted in favor of ETV. It's very important for all the patients and families of patients with hydrocephalus to be instructed about the signs, symptoms of shunt malfunction or infection, not to pump the shunt unless it's instructed to do so for specific purposes. Then prophylactic antibiotics to be used in dental procedures and in instrumentation procedures, for example, cystoscopy. And in a growing child, the need for periodic evaluation to assess the distal shunt length. And parents or patients should be encouraged to take photos of the CT scan so that we can compare as a reference when they are being evaluated for shunt tissues when prior images are not readily available. These are the references used. Thank you.
Okay.
Dr. Taspriya, for your excellent presentation, and Professor Dr. Jainul Islam sir, another panelist of today, he is also with us. Dr. Jainul Islam sir.
Yes.
Please say something and open your video.
Hello.
Yes,
Yeah,
we hear you. Taspriya, please
Good
stop sharing.
afternoon. Hello.
Okay.
Good afternoon.
Yeah, hi.
Good
You
afternoon,
need
sir.
to move. Okay, there you go. You got to center your head. Your head is at the bottom of the screen. Move your. There you go. A little bit higher.
Okay.
Higher.
Okay.
Higher.
Sorry for my participation in delay because I really was engaged in other activities. So I actually much thanks to Taspriya and Dr. Sudipto Mukherjee for their excellent presentation. We can recapitulate many things from their presentation. And Dr. Taspriya Chaudhary elaborately presented the topic, and she usually discuss all aspects of hydrocephalus in a short. You know, hydrocephalus is a big chapter for children and adults. So it has got a lot of causes, lot of fallacies, lot of complications. It's a big chapter. So in a short, Taspriya Mamta Chaudhary show us the in a short lecture. She briefed the chapter thoroughly. We can really have the recapitulate all the things. I must thanks to Tasfiya and Sudipta Mukherjee. Thank you.
Video on karo.
Professor Ikramullah sir, please say something.
Yes. Thank you, Dr. Tasfiya M. Chaudhary, for your nice presentation covering all the aspects regarding the basic concepts of hydrocephalus. That is the definition of hydrocephalus. That is the types of hydrocephalus and the presentation and the diagnosis and also the treatment. So we have learned a lot from the presentation, and we recapitulate all the things in a very good fashion. So it is with great pleasure that as we gather together to mark the session on basic concept of hydrocephalus, and this condition is often misunderstood, but with awareness and knowledge, we can better support those affected and advance our understanding of this complex disorder. As we delve into the basic concept of hydrocephalus, it's essential to recognize the challenges faced by individuals living with this condition and their families. The impact on their daily lives, education, and overall well-being cannot be underestimated. Providing support, compassion, and access to appropriate medical care are crucial steps in improving their quality of life. In conclusion, our understanding of hydrocephalus has came a long way, but there is still much to discover. As researchers, medical professionals, and advocates, let us unite in our efforts to raise awareness, promote early diagnosis, and improve the lives of those affected by hydrocephalus. By working together, we can strive for better treatment, enhanced patient care, and ultimately a brighter future for those living with hydrocephalus. Thank you for your attention and dedication of this vital cause. Let us move forward with renewed commitment to making a positive impact on the lives of individuals and families affected by hydrocephalus. Thank you very much.
Thanks, Professor Ikramullah sir. Your presence inspires us to actually establish our department and run for a long time. Dr. D.M. Arman, he is the most dedicated pediatric neurosurgeon in our department. Dr. D.M. Arman possibly have a question because he raised his hand. Dr. D.M. Arman, please open your video and ask the question or comments.
Hello.
Hi, Dr.
Yes.
Arman, welcome.
We hear you.
You
Hello.
can hear me. Yes, yes.
Can you hear me?
Yes.
Yeah.
Yeah, okay.
No video.
No
Only
video.
audio.
Yeah, your camera's not connected to the
Okay,
webcam.
no problem at all. You can ask your question.
Yeah, you can ask the question.
I'm Dr. D.M. Arman, work as assistant professor in Pediatric Neurosurgery, NINS. First of all, I would like to thank John Bennett of Neurosurgical TV for giving us opportunity to share our experience. This is great opportunity for Pediatric Neurosurgery of NINS. Today's first episode, basic concept of hydrocephalus has been discussed. Two speakers. This is a brilliant presentation. First of all, I would like to thank Dr. Tasfiya, our Phase B resident, who discussed basic information of hydrocephalus elaborately. Thank you, Tasfiya, for your excellent talk. And second topic is most important and difficult topic that was discussed by our unit head now, Dr. Sudipta Kumar Mukherjee. associate professor. In our department, tuberculosis, post-meningitis hydrocephalus, and multilocular hydrocephalus is very much difficult to treat. He lectured very nicely. Thank you, Dr. Mukherjee. Finally, I would like to thank our heartfelt thank to our pioneer pediatric neurosurgeon, Professor S.K. Akramullah sir, whose courage initiative is appreciable for development of pediatric neurosurgery in NINS, which was the first pediatric neurosurgery department in Bangladesh. And finally, I would like to thank Professor John Islam sir, whose all-time appreciation and help really beneficial to our department. Thank you. Thank you again, John Bennett.
Yes, sir.
Okay, yes, I'd like to thank you for the heartfelt appreciation. Can you hear me okay? Hello, is anybody there? Hello?
Yeah, we can hear you.
Okay, good. First, let me express my appreciation for trying this platform. I know some of you have a little bit of experience with it, but let me tell you about Zoom. I'm just a regular doctor from Miami. I ran across the platform. I saw the potential for teaching, and I've been doing it for about 5 years, mostly free around the world, because I saw the potential for people like doctors in Bangladesh to reach not just Bangladesh, but the world on the internet with a topic so important as pediatric neurosurgery. And I was so glad when Sudipka came to me and asked me if I wanted to do a series of webcasts in pediatrics, and we really need it on the internet. And don't think you're just broadcasting just to Bangladesh. You are going across the world. We don't have a lot of people, but we'll eventually build a community. This particular platform is going to be around. It's going to be a way around for you guys to learn about the new technologies that are coming. And they don't necessarily, you don't necessarily have to have high-tech equipment, just a computer to see what is being done on the internet with augmented reality, virtual reality. That's going to come, and it's going to be involved in a lot of people's practice, and it's going to make you practice better in neurosurgery, and it's not limited just to Bangladesh. So we appreciate that. Any closing comments, Sudipka?
Thanks, John. Actually, what happened in last 2 weeks, John teaches me like a teacher and I was a student, because I have very limited idea regarding the Zoom presentation as well as the webcast. For developing this first webcast in my life and telecast it as a live, John gave me a lot of effort, and he spent a lot of time, I think more than hours with me, and give a small teaching every time. Thanks, John, again.
Okay.
And thank you, Professor Akramullah sir, for attending me physically in your department. This is always your department, and we are your follower in pediatric neurosurgery. Thanks, Professor Jainul Islam sir. He always inspires us, especially he encourages us for our research work. We have a good number of research work, and he actively participates with us for research work. Thanks, Dr. Vijay Kumar. He is a sufferer of hydrocephalus. His baby is suffer from hydrocephalus, though he is doing well now. And Dr. Vijay is very dedicated to develop the hydrocephalus people, hydrocephalus community in Bangladesh. He is doing actively some research regarding the etiology and pathogenesis of hydrocephalus in Bangladesh. He is a PhD holder and he is doing some jobs in other sector, but he is a dedicated person. Thanks, Dr. Bijoy. Thanks, Dr. D.M. Arman. He is the most dedicated pediatric neurosurgeon, not only in this department, I think in this country. If everybody follow Dr. D.M. Arman, so I think the total medical concept of total medical community in Bangladesh will change. So thanks everybody. I think 2 weeks later, we can continue our discussion of hydrocephalus because around 60% of patient community in pediatric neurosurgery is hydrocephalus. So after completion of hydrocephalus discussion, we will doing discussion on tumor surgery and so other topics. Hope Dr. D.M. Arman will present his technical nuances of VP shunt placement because he has some paper already published on VP shunt placement loophole and technical nuances. And thanks everybody for give us a chance to say something in this platform. And thanks again, John.
Okay, very good. We'll wrap this up, and in 2 weeks, we'll have another talk on hydrocephalus. Dr. Arman was asking about it. It's going to be hydrocephalus in 2 weeks, and we look forward to continue. Thanks, everybody. We'll see you in 2 weeks.